So now the first presenter is Dr. Jaspreet Sukhija.
A very good morning to all of you. I'll be presenting my paper on the findings what we got when we did the genotyping of the patients with the Lebers hereditary optic neuropathy. Some of which is rare to find here. The patients are rare to find. The mutations are not, the positivity rate is quite less. So I'll just go through what we found. And so as we all know, it's a hereditary progressive bilateral optic neuropathy. Most of the time what happens is it's a sequential involvement, one eye followed by the other. And there's a male predominance because of probably the Y chromosome. Usually peaks in the second and the third decades. The literature says it's about 20 years of age. Because it's a papillomacular bundle involvement, it presents with central or centrocecal scotomas, abnormal color perceptions, and decreased contrast sensitivity. Now, the optic examination really depends when the patient presents. It could be just normal, could be hyperemic with some kind of a swollen disc. Peripapillary telangiectasic vessels are a quite diagnostic feature in the early phases. Or if they present late, they could have a temporal pallor or a total disc pallor. So the most common are the base pair mutations. What we find in these patients of LH1, these are that encode the proteins in the respiratory chains. And these are the ones which cause defects. So you have three types of mutations, the most common ones seen in 90% of the patients. It's 11778A, which really has a poor prognosis. Then you have 14484C, a much better prognosis, and a rare one, which is 3460A. Now, all these variants have been described in literature, but wherever you find, most of these studies, you have the first one, that is a 11778 mutation, what they find commonly. So of course, it was a retrospective study. We had patients who presented to a hospital with clinically suspected LH1. We did a detailed evaluation, including history of onset of symptoms, progression, family history, visual acuity testing on Snellen chart were done, visual field testing was done, pattern visual evoked potential was done, because of course we have to rule out other causes before diagnosing a patient of LH1. Genetic testing was then undertaken. So we had these patients, about 11 patients of the 31 clinically suspected LH1 patients. So of course we did not include the ones which were mutation negative. So we had 7 with the mutation of 14484. So the most common presentation was with this mutation and not with the second one, which is 11778, which most of the studies quote. And the third one was the 3460 mutation. So all patients with the 14484, that is the milder mutation, presented before 20 years of age, while the others presented later, while the mean age of presentation was 21.3 plus minus 4.7 years, which is in accordance with the literature. But in the ones with the milder mutation, the first one, this is 14484, presented before 20 years of age. So the clinical presentation was, most of them had bilateral involvement. One had ulinatal involvement, which subsequently progressed. The logMAR visual acuity ranged from 0.6 to 1.7. All had severely deranged color perception. Patients with the 14484 mutation, they had varied disc findings ranging from temporal disc pallor to hyperemic discs in 2 patients and completely unremarkable in another patients, whereas all other genetic mutations had a pale disc. And so 8 of these 11 patients had central cecal scotomas, and 2 with the 14484 had diffuse field depression, and 1 with this severe mutation had a bitemporal hemianopia. So we had a varied presentation of the visual field defects as well. Structural defects, 7 patients exhibited ganglion cell loss and RNFL thinning. So both of these were present in 7 patients, what we would expect if they present late. 3 patients had just GCL loss, but no RNFL thinning, and 1 patient did not show RNFL or GCL, the ganglion cell loss. So basically, they are patients who had an inactive but viable GCL. That is the thing to remember in these patients. All of them had decreased N75 and P100 on visual evoked potential. So we had a follow-up of 1 year, and 4 out of the 7 had progression of the disease with decrease in visual acuity, progression of the fields, 2 improved visual acuity. Obviously, these were the patients with 14484 mutation, and 1 remained stable. So, but the other ones who had a severer mutation were stable. They had decreased visual acuity at 1 year, but that did not progress, but that was a severe decrease in visual acuity. So our limitation of the study was a small sample size. Out of 31, we could get just positivity in 11 patients. The follow-up was just 1 year, so that is another limitation. So I'd like to conclude here that there's a genetic and clinical variability. The most common mutation was 14484 as compared to other studies, and they had a positive family history as well. So what I want to like to say here is that there is inactive but viable GCLs in a milder disease, which probably one can give, you can say the IDBNON which is coming up, probably you can give a trial of that for these patients who probably can improve, have an improvement in their visual acuity. So my take home message is that our profile is a bit different as compared to what is found. We have milder mutations. Why not give a trial of the medicine which is available in the market and prevent further visual loss?
Okay. Okay, thank you, Jasprit. Pretty straightforward cases. Nothing much to write home about.
That's exactly, I mean, it's just the message I wanted to give that yes, the mutation profile is different. Don't just leave it, I mean, treat them.
Okay, good. Thank you.
Thank you, Dr. Jasprit. The next presenter